My name is Dr. Angela Bader, and I'm the director of the pre-operative clinic at the Brigham and Women's Hospital in Boston, Massachusetts. And my lecture was entitled The Preoperative Evaluation of Patients with Neurologic Disease. It's important to develop a set of general principles that will help you deal with any neurologic disease, and I think the basics of the general principles include knowing the pathophysiology of the particular disorder, knowing the medications that the patient's on, knowing how that disorder interacts with all of the different organ systems. You need to be aware of any literature that is available. With all of this information, you can devise a plan that will minimize risk and maximize benefit for the patient, and obviously the patient should be informed of the risks and benefits. Make sure with anyone with a neurologic disease you do proper documentation pre and post-operatively of any existing deficits. Make sure that you also do especially an evaluation of respiratory status, because sometimes we're so focused on the neurologic disease we forget about the impact on the respiratory system. It's important when taking care of patients with multiple sclerosis that you realize that there are factors that can happen in the post-operative period that are known to increase the relapse rate, and those are things like stress and increased temperature, and also the pregnant patient is known to have an increased incidence of relapse in the first 3 to 6 months postpartum. And I think it's very important to do whatever you can to minimize stress and treat pain properly, as well as minimize anything that could cause an increase in temperature postoperatively, for example, atelectasis, because doing those kind of things that are known to have an increase on the relapse rate is probably more important than worrying about the potential risk of differences in anesthetic technique, which have never really been shown to significantly influence the relapse rate. So in the situation with multiple sclerosis, we do not feel that regional anesthesia is contraindicated, and we offer it as an option to all patients where it would be appropriate for the procedure, and we certainly offer it to all of our laboring patients. Sometimes people are concerned about medical legal implications, but they're just the same implications after general anesthesia. For example, if you do general anesthesia, you have postoperative atelectasis, and the patient gets a temperature, I don't, that the anesthetic could be blamed for general anesthesia influencing the incidence of atelectasis. So I think that as long as the patient properly understands the risks and benefits, we offer the patient their choice of anesthetic technique, especially where, for example, in the case of the pregnant patient, where certainly the stress of labor and the labor pain will be significantly reduced. The incidence of postoperative strokes is very dependent on the type of surgery that you're having. So it ranges anywhere from lowest incidence in general surgery to the highest incidence in patients having cardiac surgery or valve surgery. So it's very important to understand what the particular risk might be for the type of surgery that you're doing. And another big factor that we can influence is if the patient is on anticoagulants preoperatively, for example, for atrial fibrillation, it's very important to understand the appropriate management of that to reduce the risk of embolic stroke. Not infrequently we see patients in the clinic that are coming for elective surgery, and there is no set time in the literature about when it's safe to do an elective procedure after a stroke, but the recommendation based on a review in the New England Journal in 2007 is that any stroke in the previous 6 months should be thoroughly evaluated. So if I were seeing a patient, I would make sure that if they had had a stroke within the previous 6 months, all of the appropriate evaluations were done and no further management was needed. The problem is we don't have a good database. If I could say what I think would make the biggest impact is if there were some sort of registry for patients with neurologic diseases that were having anesthetics, because a lot of these diseases are so Some are more common, some are less common, but there's no way currently to collect the data on how patients do after certain kinds of anesthesia in a sort of registry where we can really generate enough numbers to make the research valuable. So I think in the future that's the sort of research I would like to see.